this is a great segue into our next segment, which is cardiovascular disease. So we're going to ruffle some feathers. We'll talk about particle size. We'll talk about the carnivores. Do your cholesterol levels matter? That's a good question to start with. So do your cholesterol levels matter?
Yes. All right. What's the next question?
Yeah, end of discussion. And that's our segment on heart disease. No, but there's a bit of nuance to it. And there are anecdotes. There are some people who, smoked all their life and they didn't have a heart attack. And there are some people who had high cholesterol their whole life and they didn't have a heart attack. But I saw a post that was similar to this the other day, and it made me think, it's like, yeah, your grandpa may have smoked and had high cholesterol, but he also worked out in his fields for 8 hours a day and was in terrific shape, compared to the relative population today. We know that those things are risk factors. All of the data supports it. So to kind of run through, some of that data on the lipids, and we're talking about, used to be the LDL cholesterol that most people were looking at, or total cholesterol, and now there's a shift towards ApoB. Not everywhere, but I think it's going that way. I hope it's going that way.
It is going that way.
Because it's a more predictive marker, essentially, of whether you're going to have a heart attack or stroke, a vascular event. And what you see is almost a straight line in terms of the higher your levels of ApoB and LDL are, then the higher your risk of developing cardiovascular disease. When I say cardiovascular disease, I just mean plaque buildup in the arteries, atherosclerosis in this context. So that's a pretty clear dose-dependent relationship there. And it's not just seeing that relationship, that correlation. You see also if you lower the levels of ApoB, and I think there's a formula, it's about for every, 40 points you lower your LDL cholesterol, you see something like a 20% risk reduction. I may be butchering the figures there, but we can put up a card and fix what those may be. But it's very clear, just because there's been so much study, that we know exactly how much lowering lowers the risk. So you have people on one end of the spectrum that want to lower things as much as possible. Other people saying that it doesn't matter at all, that all the data points to it mattering. And this carries over even into genetics. So some people will say, well, you can't trust those studies because they're sponsored by big pharma. And there's truthfully really not much money to be made on statins now, since most of them are generic and quite affordable. But if you just look at people that are genetically, they have altered cholesterol metabolism or altered cholesterol production, those that overproduce cholesterol, meaning really not cholesterol, but the transport proteins, are going to have higher lipoprotein B. They have much earlier and a much higher incidence of cardiovascular disease. Some people with FH or familial hypercholesterolemia can have heart attacks in their 40s, 50s, even earlier. And then you see some of the lucky ones that have a mutation in, say, PCSK9, where they clear their cholesterol very efficiently, and they have almost an immunity to cardiovascular disease. I mean, if you smoke enough and become diabetic enough, all bets are off, but they seem to have quite a significant amount of protection. So I don't know what conspiracy is used to explain that one away, but that's the gist of it, and that's how I talk to patients about it whenever they're coming in and they say, well, I saw this X person that said, oh, I have high cholesterol and it doesn't matter and this and that.
Yeah. Thinking about what matters and what doesn't, there's all these different hypotheses or theories, really hypotheses, but they all matter and they all come together in a additive or even a multiplicative way. So you have your lipid hypothesis. That's where your lipid blocks off the coronary or the carotid, and then either blocks it or sloughs off and then blocks it. So then you have the theory about blood clotting. So that's why some people take aspirin, among other benefits. It benefits lipoprotein A and maybe CRP just a touch as well. But anyway, instead of the cholesterol blocking all the way, you can have a blood clot block all the way or part of the way. And then on top of that, you can have kind of vasospasm, so almost like a TIA or anginal episode. And then you have your vasodilatory, so you lose the elasticity in your artery, you almost have rubber bands, and you lose some of that elasticity with age, so that's why some things that help with vasodilation can help as well. Then you have the inflammatory, so insulin resistance and inflammation. I think the best way to think about it in layman's terms is the cholesterol or the lipoprotein, whatever, however you want to look at it, doesn't matter. The lipoproteins, ApoB, for example, and then the macrophages, the immune cells that turn into foam cells. So you have your inflammation coming in and actually making it part of the plaque, the glue, if you will. And then you have the lipoproteins or the blocks. So the blocks plus the glue makes it particularly sticky, and that's how you build the plaque wall. So if you're betting that your glue is going to be very low, the blocks are not going to matter as much. And if you have both, then you're going to build up your plaque extremely quickly, regardless of whether it's calcified or non-calcified, regardless of whether it's stable or unstable as well. So ideally, at least, according to the evidence and also in theory, an N of 1, you might be okay, but you wouldn't want to have as few blocks as you can without any deleterious effects, and as little glue as you can concurrently.
Yeah, and I think it's really, the way I say it is it's a numbers game. So the odds are that if you have this level, that this is your risk. And that's part of a larger algorithm. But just to look at the lipid section, we understand pretty well those risks. And some people are like, well, I don't care. I'm not going to do anything to lower it. And in those cases, you can say, okay, that's fine. There's no need to destroy the patient-provider relationship over that. You can monitor that. You can explain the risks. You can say, okay, when you're 40 or 50, we'll get a CCTA and we'll see, was your hypothesis correct or not? It's a very N of 1 experiment. So is there plaque there? Is there not? And then that's some very objective data. And people will talk about the calcium scores, and they'll say, well, I had my CAC and it was 0. It's like, well,
you're 40 years old.
23 years old.
Yeah. No time to calcify.
Yeah, and I think if you look at about age 40, it's not a super high incidence of people that have positive calcium scores. So if you do a calcium score on people who are 70 or 80, it's a very different story. You can have a very high incidence of calcified plaque by that point. And if you do a CCTA on a 80-year-old, it's going to be a very, very high likelihood that you see some stenosis there. So you want to keep your arteries clear, presumably, as long as you plan to be alive, whether that's 65 or whether that's 125, or whether you think you're going to live forever, which is a whole other podcast. We don't want to get too far off track. But essentially, there is a bit of a warranty period depending on how healthy you are with your calcium score. So if you look at people who are not super high risk, on average, 5 years after they get a calcium score of 0, there's about 20% of these people who actually have a vascular event. So 80% of them are in the clear, 80% of them, or 20% of them have a vascular event. We can put the link to that study in the description. I thought that was particularly interesting. But if you have somebody who's smoking and diabetic, or if they have a coagulation disorder and they have a CAC at 0, again, very different story, very different risk profile, which is why I think you and I both really individualize the cardiac risk assessment.
Coagulation disorder, especially for an individual on something, for example, testosterone or estrogen, that will affect platelets and that will affect that HMG ciliary reductase enzyme. So testosterone will basically activate the same enzyme that statins and many lipid medications inactivate. So if you're on estrogen or an androgen, you are on a lipid medication. So if you don't want any lipid medications, you might want to stay off of those. But you made a great point with the coagulation disorder. There's an individual, very respected and esteemed individual named John Meadows, and he was public about having a very low calcium score. I believe it was single digit, which for his age was quite good, and he had a very healthy lifestyle, and he did have a cardiac event. He had a heart attack, despite having that low, apparently due to a coagulation disorder.
Yeah, and these things can happen. Could it have been predicted? We can go back in hindsight and argue that all day long. But at the end of the day, you do want to do the things that are associated with better outcomes. I mean, I'm almost a hyper-rational person, so I want to make sure that my numbers are in the low-risk category. I don't want to take a bet that over the next 20 years in this gray zone that I'm just going to slide by and not build up plaque, even though I'm doing things like exercising and eating vegetables and fiber. I just don't think that that's enough to say if my cholesterol is high that I'm going to skate by or get off scotch-free.
Yeah.
And then there's the particle size argument, right? So if you have larger particles, then it doesn't matter. And there was a recent clip that I saw put out by, I'll just say someone in the carnivore community. I won't name names, but they had previously made the argument that, well, they have lots of large particles, so their lipids are not atherogenic. And then in the recent blood work, I believe it was either an NMR lipoprofile or they had maybe a small dense LDL on there. And the number of small particles was also much higher than you would like to see. So not only did they have a lot of large particles, they also had a lot of small particles. So it's kind of at that point you have to keep moving the goalposts, because what you said in the past, the large particles, now you have small particles that are there. And I don't know if people are following along that closely, they're going to pick up on that.
Even if the particle size itself does not matter, a high small dense LDL or a particle size being off will lead to insulin resistance, which I believe everybody agrees matters.
Yeah, absolutely. And just with the particle size, another theory that I heard was, you have these transport proteins, and obviously a larger, I've heard people talk about them like, your boats or things that transport your proteins, and a larger particle is going to carry more cholesterol. So if a larger particle does get into the artery, let's say there's a lower probability of it, say 50% less likely to get into the artery, but it carries twice as much cholesterol, then your numbers cancel out. You're just delivering a larger load of cholesterol into that subendothelial space. Now, whether that plays out, it's probably impossible to study. Lipidologists can probably theorize about that and know much more than I do, but I mean, it's just not a way where I'm willing to look at a person and say, oh yeah, all big particles, you're good to go. I think that would be misleading based on the evidence that I'm aware of.
I agree with that. If you're looking at a scenario and you're saying, I'm the exact same person, do I choose 20 large HDL particles or 20 garbage trucks that are huge, or do I choose 20 tiny garbage trucks, since that's kind of what the HDL particle is? Then obviously you're going to choose, in general, the larger ones, or the light fluffy ones, whatever term you want to call. But in reality, it doesn't look like it's really a choice between the two. It's rather just a measure of what you discussed, how easy to enter and how much can be carried.
Yeah, and certain things can make this easier. So if somebody has a glycemic excursion, your blood glucose spikes up to 200 after you hit the buffet. It shouldn't happen if you're metabolically healthy, but just for sake of the argument, then that's going to put you in a situation where those particles are much more likely to enter. Same thing after you smoke a cigarette. Those particles, your arterial system is going to be irritated. Those endothelial spaces are going to be much easier for those transport proteins to get through. So those are a couple of things, and I really liked your analogy of testosterone as a reverse statin, because essentially, it does speed up that enzyme, and you can see with androgens in general a dose-dependent reaction, and people who are on very high doses of androgens, not always, but will tend to have higher levels of the ApoB and LDL cholesterol transport proteins. I like to think of the carnivore diet as a reverse PCSK9 inhibitor. Not necessarily the direct mechanism, but you're really, with that amount of saturated fat, reducing your LDL receptors in the liver, being able to clear out the cholesterol. So you're going to have just a buildup in higher circulating levels, which is why we see some of these things that are like, you have a cholesterol level of 600 and 500 of that's LDL, or an ApoB of over 200, 300, and I've seen some of those lab works, and it's quite alarming, but you do have to realize that this process happens over years and really decades, but you want to spend as little time in that high-risk environment as possible.